So at the outset, I would like to thank Dr. Manoj Chawla, Purvi Chawla and his team for inviting me to this wonderful conference. Indeed, my great pleasure to be here. So for the next 18 to 20 minutes, I will be talking on from research to practice, the future of DiabetoCardiology. Medicine is essentially a resolution of uncertainty, and this has time and again been proved on several occasions, and it aptly applies to DiabetoCardiology. All of us has dreamt of gene therapy in past, and now genomics and molecular medicine has stepped down from the lab to patient care and is running the front race in current cardiac care and cardiodiabetology care, as I'll show you. All of us know glycemic control is an integral part of treatment of diabetes, and CGM has been a revolutionary step in this direction. But 70% of diabetics die because of acute myocardial infarction, and therefore if you want to increase the longevity of life of a diabetic patients, the attention has to be focused on acute myocardial infarction, and therefore save the heart should be the key step in the treatment of type 2 diabetes along with all other modalities of treatment. Now ASCVD, all of us know, is a multifactorial disease, but one of the major culprits for acute myocardial infarction is LDL cholesterol, and if you want yourself to be protected from acute myocardial infarction, the LDL lowering is a lifelong marathon that you have to clearly understand. You have to keep your LDL lower, what limit I'll be alluding to. We have data that if you want to arrest progression of atherosclerosis, the level is less than 70, data from the reversal trial, as you can see. If you want regression of atherosclerosis, LDL has to be less than 50. And therefore, if you continue to walk through this cardiovascular pathway with an LDL of less than 70 from early age, you will walk through it without any subclinical disease, without a myocardial infarction, and without any stent implantation, vast majority of the times. You have to remember that acute myocardial infarction only develops when the cumulative exposure of LDL to the arterial wall reaches the threshold of 7,000 milligram per year. So it is the cumulative exposure of LDL to the arterial wall which is of paramount importance in development. The earlier you achieve lower LDL and maintained it for a long time, more will be the benefits. So what are various options which are there? We have daily medications, we have bi-monthly medications, we have biannual medication, but the problem with all these medication is it is very difficult to have a good compliance. Suppose you ask an individual take medicine for 10 years, 20, it's very difficult. But now gene therapy has provided us with a unique modality, once lifetime treatment. So the technique is CRISPR-Cas9 technology. Now this has two components, as you can see, a guiding RNA, which locates the specific genomic locus, which is PCSK9 in this context, and the Cas9 nuclease produces a double strand cut in the genome. So this you will see. Now you will see that the guiding RNA will locate, this has located the PCSK9 gene, and the Cas9 has produced a double-stranded cut in the genome, and when it heals, as you will see, it produces loss of function mutation of PCSK9, and the individual becomes loss of function mutation, and the LDL drops to very low level for the rest of life. So this is a single-time treatment, and the HEART-1 trial in New Zealand is ongoing with this molecule, which is an intravenous infusion, VRV101, and you can see we used in the dose of 1.5 milligram per kilogram, the reduction in the level of PCSK9 level in the blood, normal being 35 to 25, is to the tune of 89%, and in LDL level at 68% for the rest of life. So single time treatment to lower LDL may in times to come may be the modality. You have to remember that if you want to win the battle against atherosclerosis, you have to directly hit at the plaque. No plaque, no atherosclerosis. And if you want to hit at the plaque, you have to have intensive lowering of LDL. It's not 10 milligram or 20 milligram. And you have to maintain your LDL at least less than 70, even for primary prevention. For the very high risk patient, much lower. So gene editing is going to strip off the LDL villain. And we have published this article, Postponing Acute Myocardial Infarction for 100 Years, in Emerging Concept in the World Journal of Cardiovascular Diseases last June 2024. And our great Bonwald also thinks in this direction. The other unresolved issue is that LPA-induced cardiovascular disease, we do not have any approved drug at the present state of time, and all of us know this is a deadly disease. How gene therapy is going to alter LPA? There are two ways in which LPA can be tackled by gene therapy. One is the ASO therapy, that is antisense oligonucleotide therapy, and the concept of this is when you inject drug which work on ASO like pelacarsen, it binds to the messenger RNA, destroys the messenger RNA, and therefore ApoA cannot be formed. Once ApoA cannot be formed, LPA will decrease. And this is pelacarsen is being introduced. It reaches the cytoplasm nucleus, combines with the messenger RNA. This duplex is cleaved by RNA and messenger RNA is degraded, so ApoA cannot be formed. And the Horizon trial is ongoing, very likely to be released in early 2026. The other way is to utilize small interfering RNA. The principle of small interfering RNA is when you inject small interferon, it again combines with messenger RNA, cleaves it, and therefore the protein cannot be formed. And three small interfering RNAs, olpasiran, lepodisiran, and zerlexan, are in late stages of development. And we also have an oral molecule, novalbuclin, which is undergoing phase 3 trial. And the beauty of these molecules is they lower LPA to the tune of 90%. LPA-driven cardiovascular disease is considered a slow death warrant because of premature development and malignant progression of ASCVD and currently lack of any approved therapy. But if pelacarsen and small interfering RNA, the trials come out to be positive, LPA-induced cardiovascular disease will become a salvageable disease in future, and this will kick off a new revolution or a new dawn of LPA therapeutics. And this vacant place, no drug approved for LPA, is likely to be filled in future with pelacarsen and other drugs. Today, only no drug is approved for LPA. Can mixed dyslipidemia be targeted by gene? Again, the answer is yes. Small interfering RNA targeting NPTL3, and this is the prolonged trial. You can see marked reduction in TG to the tune of 60% or so, marked reduction in VLDC, marked reduction in LDL and non-HDL cholesterol. And sometimes we do see patients of marked hypertriglyceridemia. And the solution to this is again antisense to ApoC, and you can see this is olezarsen, which has been approved by FDA after the BALANCE trial, 80 milligram once a month. The previous drug, valnocirnon, was not approved because of serious bleeding, but now we have this drug which lowers triglyceride by 43%, and you can use in these genetic hypertriglyceridemia. So time has come to rewrite the script of lipid management. If you review or if you read any script of lipid management, genetics is not there in the treatment of dyslipidemia, but a lot of advances, and therefore time has come to rewrite the script of lipid management. Unfortunately, if you develop acute myocardial infarction, we have a panoply of modalities to assess your coronary circulation and you treat atherosclerotic disease in the coronary arteries. Gene therapy is also advancing in the treatment of hypertension, and with gene therapy, blood pressure is taking a vacation. Why we are saying the single injection of zilebesiran, a GalNAc conjugated angiotensin and sirna, decreases the production of angiotensins, and with a single injection, your blood pressure can be controlled for the next 6 months. The other issue we have been hearing is obesity is rocking the entire world, running the front race in cardiometabolic diseases. And if the current trend continues, nearly 2 in 3 adults over 25 would be overweight or obese. We have lots of drugs you have already heard in the morning, but it is semaglutide and tirzepatide which is running the front race, and retatrutide is ongoing evaluation. But the big question is, do these drugs improve cardiometabolic outcome? The answer is a big yes. And this is the evidence from several trials in various subsets of atherosclerotic cardiovascular disease, CKD, OSA. So time has come to project the new face of obesity. What is it? Obesity is a disease. It's not only a disease, it's a new diabetes. If you treat obesity, diabetes would be minimized. And the other dicta is, with the new OAMs, treat obesity today with the new OAMs like semaglutide and tirzepatide, protect the heart, liver, kidney for tomorrow. And as you can see, the guidelines also, a fifth pillar is added by ADA, obesity management, which is very, very important, and all of us are discussing round the clock for this. Digital twin technology, I think, is again a great advance in the treatment of diabetes. Whole body twin technology for improving metabolism and remission or reversal. And this allows personalized and proactive diabetes management. Various metabolic parameters are detected, and with the help of an artificial intelligence and computer, a twin is created so that you can know this individual, what happens to his various metabolic when he takes food, when he takes exercise, and you can appropriately advise that patient. So with this twin technology, in the first 3 months, the blood sugars are normalized. Then in the next 3 to 6 months, healing chronic conditions like blood pressure, cholesterol, obesity, and improves organic health in the 6 to 9 months, and regeneration of beta cells in 9 to 12 months. And what is the data? Now, this is a 1-year outcome of digital twin technology for type 2 diabetes, a retrospective real-world study. You can see significant improvement in HbA1c after digital technology intervention. Improvement in CGM metrics, you can see the green line, tremendously improved. Significant reduction in the anti-diabetic medications, less anti-diabetic medications are taken by the patient. Digital twin technology is a big step in diabetes management and could play a vital role in the future of type 2 diabetes care. Gut microbiota and type 2 diabetes, again, gut microbiota are important in the pathogenesis. They produce microbial dysbiosis, they produce inflammation, insulin resistance, and work is in progress with fecal microbiota implantation so that if this comes out to be positive, besides the conventional therapy of obesity, such as diabetes, bariatric procedures, and other drugs, this may become another modality of treatment. Regenerative and stem cell therapies in cardiovascular therapy. Now we are talking of heart failure. All of us know heart failure. Once sets in, it runs a malignant progression with a very high morbidity and mortality. The 5-year survival is to the tune of 50%. More diabetic die of heart failure than acute myocardial infarction. And the big problem with heart failure is drug therapy, device therapy, no doubts blunt this malignant progression, improves survival, but does not arrest, so that the end result is dismal. And therefore, cell therapy emerges as a very exciting option, but after several decades of research, we do not know if the beginning of end or end of the beginning, but research is ongoing, and in times there may be positive trials. Then we have a lot of innovative molecules, all of us are familiar, and SGLT2 is the molecule of the first quarter of the century, is a multi-saturated blockbuster drug. The beauty of this molecule, it can be used across the spectrum of heart failure, irrespective of the ejection fraction. Beta blocker stops benefit at 40%, RNA 55%, MRA 50 to 55%, and it slows down the trajectory of CKD and postpone dialysis about 10 to 15 years, and that's what we want. SGLT2 inhibitors continue to surprise us, and this time the surprise is given by a positive trial in valvular heart disease, patient of aortic stenosis, past history of left ventricle failure, undergoing TAVR. So in times to come, you will see SGLT2 inhibitors being used in valvular heart disease. So we continue to learn with SGLT2 inhibitors. CKD also, previously we have 3 molecules which slows down the trajectory of CKD, RAS inhibitors, SGLT2, non-steroidal amylase, that is finerenone, but now the flow trial with GLP receptor agonists has also come out to be positive. So now we have 4 pillars, but unfortunately all these molecules are started late in the course of CKD. CKD diagnosis delayed vast majority of the time. The other important complication is MASLD. You can see normal liver and the fatty liver. And why we are so much interested in MASLD? Most of the patients in MASLD die because of a cardiovascular event and not liver disease. Only a small number develop cirrhosis and liver cancer, because MASLD is a gateway for cardiovascular disease. If you have MASLD, you will likely to have cardiovascular disease. In fact, it's a red flag for development of atherosclerotic cardiovascular disease. So you must utilize all preventive measures once you develop MASLD. But cardiologists, unfortunately, even cardiologists hardly paid any attention to it, although this is now being increasingly addressed. And we have this new drug, resmetirom, beside the old drugs which are useful, and this trial is positive. Resmetirom is likely to be introduced in India also by Lupin within a couple of months. The other advance which has occurred is that heart diagnostics have come on your screen, on your mobile, wearable digital technologies, devices. You can know multiple parameters in real time, blood pressure, glucose, weight, sleep, and so on, and you can act accordingly. Artificial intelligence is another new development and maybe the future of medicine. So you can have interpretation of electrocardiogram, echo, MRIs in a much better way, and it helps in several other ways, as you can see, because self is a separate chapter to be discussed. When we talk of type 1 diabetes, unlike type 2 diabetes, where remission is always a possibility, although may not be sustained, but cure of type 1 diabetes is still elusive, but slowing its progress is possible. All of us know immunotherapy with tebelizumab can delay the onset of type 1 diabetes by 2 years or so, but beta cell replacement regeneration trials are ongoing. In times to come they may be positive, and gut microbiome is another area where research is continued unabated. And we have published this from research to practice in the Curious Journal. So progress never stops. Innovations in the cardiodiabetology continue and is likely to improve the outcome of patients. Thank you very much for your kind attention.